the topic is on kissing balloon inflation. Should I be doing in all cases of bifurcation PCI? Are there any long-term effects? So I need to answer two questions over here. Should I do in all cases of bifurcation PCI? Number two, are there any long-term effects? Now, when do I do a kissing balloon dilatation? Two situations. One is provisional strategy to address the side branch, or when I use a double stent to do a kissing balloon dilatation. These are the two situations. Let us take the first situation, provisional strategy, whether to address the side branch with a kissing balloon. To kiss or not to kiss is a big dilemma, as I'll show to you what is the scenario like. First scenario, this is almost a CTO. This patient comes with angina, chronic stable angina, TMT is positive, there is some retrograde flow, and then you can see when we did an OCT, we could see that there was a lesion which is almost from the left main, almost extending to the LAD. So what we did was that we gave a stent from the left main to the LAD. So it was a single stent strategy. You can see the angle is quite wide. So here, if you try to see the post-OCT pictures, there is no strut across the LAD and the circumflex. So this establishes the fact that there is no need to kiss at all. So these are the situations where possibly you don't need to kiss. Here, if you take a 3D view, there are no struts across the side branch, and definitely there is no need to kiss or no need to go ahead. Let's take a scenario 2. This is a similar type of situation with the ostial LAD extending to the left main literally, because you have to stent from the left main to the LAD, and the angle is quite narrow. So when when we did this thing that is LAD to LMCA, we took a run, we could see there was some plaque in the left main, and first a cutting balloon was used, a Ulverin. You can see the beautiful cuts that have taken place, and then is stented with a single stent strategy from LMCA to LAD. And then what was seen was that there were struts in between, there were crowding of the struts in between the circ and the left main. So one, you can see that there are few struts that are this thing. So these struts were questioned whether these struts would cause any problem. So these struts were, question came whether we have to kiss this or not. Now, sometimes what you do after you do a pot, you might take a small balloon and try to just push it across and try to just open the struts or do a kissing. And this is what was done after the pre-dilatation. You can clearly see that there are no struts, but the question is it essential? Let us try to see what the studies say. If you come to 2015, when the final kissing balloon inflation, the whole story came, it was basically that it was to optimize the side branch strut. So that is why the reason for the kissing balloon dilatation came into being. But as we grew further and further, we saw that the geometry had to be changed so that the coronary flow would be better. Now, if you try to see some literature quite back, some years back, it was shown that if it was a jailed side branch, it all depended on the side branch width. If the side branch diameter was less, it was seen and the struts were across, then one could see that gradually with time, the link group, they started having restenosis. So the question came that on an 18-month follow-up, this study showed that the side branch started having restenosis. So the question came that should we routinely do it? The OCT analysis showed that definitely at the almost 1.5 year, if there were struts left across the side branch, this would cause problems. The initial studies was that the final kissing balloon, these were studies in 2015 to 2017 when they clearly came with the guidelines or the study that final kissing balloon as a single stent strategy is the treatment in non-left main lesions in ACS patients. So there were views which were published that definitely you have to kiss it. But then gradually as we went on, this COBIS registry clearly stated with a one stent strategy, final kissing balloon is associated with a favorable long-term clinical outcome, mainly dependent on the reduction of TLR in the main vessel or both vessels as a result of the increase in the MLD. So the concept was that try to achieve a bigger MLD in the side branch so that you could do well. But what the AOI LMC registry stated that it was clearly stated that as we moved to 2019 that the final kissing balloon is with a one stent strategy did not affect the TLR and other clinical outcomes during a 5-year follow-up. So we came into more evidence that it is not necessary to go for a kissing balloon dilatation when you're doing a single stent strategy. And this is in press, this is not yet published, this is in our Indian Heart Journal, where they compared two groups, that is the kissing balloon versus the non-kissing balloon in the two arms, and they clearly stated in this multi-center real-world registry, kissing balloon dilatation did not improve the long-term clinical outcome in patients with coronary bifurcation lesions treated with a provisional stent strategy. So the take-home message is that you did not do side branch kissing in a provisional stent strategy, and this was a meta-analysis which has just been published around 3 to 4 months back, which stated that the meta-analysis also indicates that KBI may be associated with an increased risk of the main vessel restenosis and a decreased risk of the side branch restenosis. So as we move from 2015 to 2022 or 23, we see that it is not necessary that the side branch has to be kissed, but the question came that there were editorials and bifurcation lesions, the simpler the better. Coronary bifurcation lesions, the less metal, the better. Where should I kiss then in a single provision strategy? The answer lies in imaging or physiology. Kiss if the stenosis is more than 70% or 50% plaque burden on IVUS, FFR less than 0.8, QFR less than 0.85, IFR less than 0.9. So this is the take-home message in provisional stenting, where you possibly have to think of doing an imaging or a FFR before deciding whether you need to kiss. Now the second subset, double stent strategy, do I kiss? Now, if you see the kissing balloon dilatation in the Medina 111 classification, it is a step 6 that you give the first kissing balloon, then it is a step 10 that you do a second kissing balloon, and then the final results are good. So after the 11 steps that you follow, or the 9 steps what people say, there are 2 stages where you kiss. Now, why do we kiss? Let us take a case 1, a scenario where there is a diagonal and a LAD. And what you can see based on the CT angle and the BPCT angle and the length, you can clearly see that this is a 2-stent strategy that I have to follow, and that is what I did. And in fact, the 2 wires given, 2 balloons, 2 stents, and finally a kissing balloon dilatation. This is the pre and the post stenting results. And what we saw was that there was no strut across this thing, and it was a new carina that had been formed, and the results was good. So this is the beauty of doing a kissing balloon in a 2-stent strategy, where you can see the side branches are well opened up when you do a 2-stent strategy. Now let's take a case scenario 2 in which there is a left main disease, and where there's a 100% occlusion of the circ. The POBA has been done to the circ. And then we go ahead and do a DK crush with 2 stents, finally do a stenting, and this is the result that we get with the final kissing balloon, that you can see the results are good. So this is a second scenario where it's a left main subset, where you do a 2-stent strategy for a circ and a LAD to left main. And this is a 6-month follow-up where you see that the LAD is clean, the circ is clean, and the carina is totally good, and the LMC also is totally sacrosanct, and there has been no restenosis. So this is one situation where you have to go for a kissing balloon dilatation because you have to make a new carina. Now, why do we kiss in this? The kissing balloon inflation is for the carinal reconstruction is mandatory in 2-stent strategy. And in the face of the cunning enemy, we know that DK crush writes the legend and is the best procedure so far as all the 2-stent strategies are concerned. This is a state-of-art review about the percutaneous coronary intervention, where they have stated that you first do a pot and then you do a repot, and there are a lot of controversies, but definitely a kissing balloon dilatation is important. If you go through the DKC trials, the DKC 1 to the DKC 6, and of course the DKC 7 is going on, all these DK crush trials do show us that the MACE, ISR, TLR, TLF, TVR are all less if you do a kissing balloon dilatation final. So here we learn that definitely on a 2-stent strategy, you need to go for a kissing balloon dilatation. This is something very important which has just been published about the vascular healing after kissing balloon dilatation. Very importantly, it was studied that if you do a kissing balloon dilatation 2-stent strategy, the results are in favor of a midterm vascular quick healing. This is very important. So if I have to conclude, where do I need a kiss? Provisional strategy to address side branch? Definitely no. Do an imaging and physiology. If it is mandates, then go for a kissing balloon, but be careful. If you injure your side branch, you might have to put a second stent. Now, if it is a double stent strategy, definitely yes. You have to go for it because the long-term results are good. Thank you for the patient hearing.
Thank you, Dr. Sahoo. I think, crystallized and clarified the matter very well. And if there are any comments from, so I think, this is very clear that yes, in a 2-stent strategy, definitely we are going to do it. And in the single crossover stenting, basically, in those cases, So one last, point about whether you will still rely on the imaging or only in physiology only, or maybe some angiographic picture. If you find the circ is flowing very well, would you still do imaging?
Yes, yes. No,
You will. Thank you very much.
Thank you.